Thank you, Professor Spali, for your kind introduction. I'm really honored to be here today, and I want to thank you for spending your lunchtime here. And I would like to thank again Professor Spali for the opportunity to visit the University of Rijeka and to participate at this Sunday school. Again, I'm sorry for my bad English. If you don't understand something, please stop me. Okay? And with the help of some colleagues, maybe it's possible to translate from Italian to Croatian if some gaps arise. And before to start with the lecture, I just want to present our school in really briefly. Professor Spali introduced where is Trieste, but all of you, of course, know where Trieste is located, very closer with the Slovenian border, but also just 1 hour and 50 minutes from Rijeka. Trieste is all the streets, architectures, and buildings are strongly influenced by the Habsburgic Empire. In fact, Trieste has conveyed by the Habsburg Empire. And so streets, squares, and other stuffs are very similar with Austrian cities, in particular Vienna. Here you can see some places and attraction of the city. This is the San Antonio Church with this canal during the evening, or another beautiful place is the lighthouse during the most important festival in Trieste, called Barcolana, when more than 2,000 boats are engaged in a race in the harbor of the city. Again, this is the Piazza d'Italia Square, the biggest square located in front of the sea in Italy, and during the evening is very beautiful place, I think.
Yeah.
Trieste was our city.
Yeah. Austria, because yeah, Yugoslav city for a short period of time after the Second World War.
Miramare Castle, this is the summer residence of Habsburgo emperors. And of course, the Borough, Trieste is famous for this, but also Rijeka, I think,
Yes.
because in some of these winds strong, very strongly the city in particular during the winter. Okay. And about the university, is pretty antique. In fact, the university has been founded in 1877, again by the Habsburg Emperor. And we have almost 20,000 of students with 12 faculties or departments. One of these is the Department of Medical, Surgical and Health Sciences. Inside of this department, there's the School of Dentistry. The formative offer of the School of Dentistry is 200 graduate programs in School of Dentistry and School in Dental Hygiene, and of course also postgraduate programs in orthodontics, in oral surgery, in pediatric dentistry, and again some PhD programs in dental sciences. I'm sorry if the slides are not correctly, but we change now from Keynote to PowerPoint, and maybe something doesn't work correctly. The clinical activity is performed in the hospital in the center of the city, the major hospital. We have 11 dental units that cover the entire dental activity. We have 38 chairs, and we perform more than 80,000 dental acts per year. It's a big reality for the Italian standards. And about orthodontics, the staff is composed by 2 associate professors, 1 postdoc fellow, 4 tutors, and 11 clinical instructors. Our program is a 3-year program. I have 4 residents per year. And at the end of the treatment, each resident treated about 50-70 patients each. Here you can see a picture that we took 3 years ago, I think.
3 years ago.
Yeah, 3 years ago, when Professor Spali visited our school inside of an Erasmus program. And our school is deeply engaged also in research. Our favorite research lines are growth indicators, functional orthopedics, the topic of today, and systematic review and meta-analysis in different fields of dentistry, and orthodontic materials, now in particular mini-screws, and of course also the clinical approaches on the basis of literature and our experience. I'm proud to say you that what we are talking today, I and Dr. Perinetti, both also in the United States in a visit performed 2 years ago. We visited St. Louis, the university, the Virginia Commonwealth University, and the University of North Carolina. The dean of the first one is Rolf Behrens, and Behrens is the editor of the American Journal of Orthodontists. The dean in the Virginia Commonwealth University is Professor Lindauer, the editor of Orthodontists. And of course, the third is the House of Profit. Okay. And today I want to present you a very, very similar presentation with something more, because this lecture was presented 2 weeks ago. Okay. When we talk about the class 2 occlusion, it's very, very important. The first thing, recognize a real class 2 malocclusion due to mandibular retrusion. Because the bigger round that we can perform is try to treat a class 2 malocclusion orthopedically, but there's no indication because the problem is not orthopedic, but dental veer. And we have 3 ways of analysis. The first one, a skeletal diagnosis. The second, the intraoral occlusion, intraoral aspect, and the profile analysis. Regarding the first one, I don't know what is your favorite cephalometric analysis, but it's not important. We suggest to consider a real class 2 malocclusion only data that overcome the first standard deviation in terms of mandibular retrusion. We use the EBO-IBO cephalometric analysis, and in our opinion we have to consider class 2 only data for the mandible lower than 78. Okay? Don't consider a skeletal problem if you don't have this data. Okay? Intraorally, you can see 2 kinds of occlusion. A full cusp class 2 molar relationship and canine relationship, or half cusp or edge to edge. We consider this condition a real skeletal problem because sometimes this is only a dental alveolar problem. And of course, the profile. Okay? If you sometimes are in doubt if the problem is in the maxilla or in the mandible, we suggest to cover the part of the head. Okay? Yes, the animation works. And to analyze the head from this point of view. If you see the position of the maxilla harmonic, probably the problem is only in the mandible. Combining these 3 analyses, you are able to detect a real skeletal class 2 malocclusion due to mandibular retrusion, the topic of today. And the treatment of class 2 malocclusion is strongly influenced by 2 concepts, the growth and the timing. Boring arguments, in particular the first one. But I don't want to talk too much regarding this. But I want to tell you that each individual present during the circumpubertal period an increment in the growth velocity of growth, recorded through the statural age. This increment in growth velocity is characterized by a prepubertal minimum, followed by a pubertal maximum that precedes the complete growth. And this pubertal maximum is known as adolescence. Okay? During this period, of course, also the maxilla and the mandible grow, but they follow how modalities, and the comprehension of which are fundamental for the success in orthopedics, in dentofacial orthopedics. Regarding the maxilla presents a subpleural growth that starts in the early childhood and infancy, when all the sutures are really immature and continues until adolescence, when all the sutures start to the sutures are thickly interconnected and then fused. This changing in the suture has been shown by Birte-Mertens a lot of years ago in histological images on human specimens. This is clear, and this is a very antique knowledge. A slight different behavior characterizes the mandible. In fact, the mandible presents a condylar growth, mainly condylar growth. And Jos Bjorn, some decades ago, showed that the growth of the condyle follow the increment in age of the patients. For this reason, the condyle or the mandible present a growth peak at the same time with the increment in age. Quindi it's present a pubertal growth peak. But to be short a long story, I want to tell you that to have the main results in the orthopedic treatment of the maxilla, the correct timing is treating the patients during the prepubertal period. And if you want to treat with the right timing the mandible, you have to treat during the pubertal period. At this point, it's more than clear that the identification of the pubertal growth spurt, the start of this moment, because it's the end of the growth of one bone and the start of another bone, is a key point. Absolutely a key point. We use a lot of literature, and now I want to show you this systematic review published by an Italian group from the University of Messina. And they analyzed the effectiveness of orthodontic treatment with functional appliances of mandibular growth in the short term. The inclusion criteria of this group of authors were the most important studies, the randomized clinical trials. Okay? And the authors detected just only 4 studies, okay, in this systematic review. The conclusion of this systematic review was the analysis of the effect of treatment with functional appliances versus an untreated group showed that the skeletal changes were statistically significant but unlikely to be clinically significant. This is a very bad news. Okay? On the basis of these results, of this conclusion, probably these 2 cases are hopeless cases. Okay? We are unable to change this phase. Of course, without surgery. Okay? But we treated these patients. The first one at 11 years old with Frankel, and the second one with twin block at 14 years old. And as you can see, both of them obtained a great improvement of the profile. Something is happening. Okay? 3 years ago, we published 2 studies, and we analyzed the treatment effect of fixed functional appliances or removable functional appliances in class 2 patients. Okay? These were 2 systematic review and meta-analysis. Our inclusion criteria was retrieve all the studies in literature, not only randomized clinical trial, but also longitudinal controlled study, either prospective or retrospective. All the studies use a removable or fixed appliance. The use of an untreated matched group of class 2 subjects as a control, and for the first times, they use a reliable indicator of skeletal maturity. In other words, the author stated what was the stage of maturity of the patients and classified in prepubertal, pubertal, or postpubertal. Here you can see the studies analyzed in the literature, only 11 for the removable appliances and 11 for the fixed. And please note that inside of these papers, only 3 are randomized clinical trials. The others are sole controlled clinical trials, just a little bit low in the pyramid of evidence in the literature. Regarding removable appliances, the most investigated appliance is the twin lock, followed by Bionator, but also Sander and Franke too. And the only comparison possible in these studies was from patients treated during the prepubertal period or pubertal period. From this study, we obtained a lot of data, but today I want to show you just the main result. And the main result is this one. Okay? When we treat the patients during the pubertal growth peak, we obtained 3 millimeters of supplementary growth recorded through the line condylom gnathia. 3 millimeters, and this is an annualized data. Okay? If you treat the patients in the pre-puberty, you have a lot, and you have only 0.95 millimeters. Okay? So the correct timing is this one, the pubertal growth period. And interestingly, the major amount of growth is in vertical dimension, not in sagittal dimension. It means that when we treat a patient with functional appliances, we don't change the vertical pattern of the patient. Okay? We are able to improve the dimension of the mandible along the facial axis of the patient. Okay? It's very important. And in the last slide, I will talk you about what important is the vertical pattern. And skeletal effects in the maxilla are really limited. Okay? Regarding the fixed appliances, the most investigated was the Herbst, followed by a lot of other fixed appliances. Mara, Advalsins, Forsus, Sidney Magnoglide, SUS, a lot. In this case, the only comparison possible was between patients treated during the pubertal period and post-pubertal. So a slight difference compared with the removable appliances. And what is the reason? The reason is if you use a fixed appliances, probably you use the appliances in the permanent dentition. Okay? And of course, during permanent dentition, the prepubertal period is almost always a pubertal period, not prepubertal. Look the same data. The elongation of the mandible is 2 millimeters when we treat during pubertal period, and no effect if you treat the patient after pubertal period. The comparison between removable and fixed is there's a difference, okay, 1 millimeter, and the reason is that the fixed functional appliances induced a dental compensation of the frontal incisor, lower frontal incisor, and this compensation is the overjet that you need to implement the sagittal position of the mandible. Okay. So this data doesn't mean that the removable works better than the fixed. Okay? The only problem is that the dental viral effect is lower in the removable appliances. And now I want to go back to the systematic review that we saw just some minutes ago. And I want to show you the 4 studies, what kind of patients they are treated, they have treated. Okay? In the study of Jacobson, patients were from 8 to 9 years old, prepubertal period. In the Nelson, 10 to 13. probably pubertal patients and prepubertal patients. In the study of Tulloch, yes, the patients were in prepubertal period because the author used a method to identify the skeletal maturity, the Henry-West maturation method. And in the study of O'Brien, all prepubertal because the author used the CDM as a skeletal maturator indicators. In other words, all these randomized clinical trials treated the patients in prepubertal period. And now we know that if you treat the patients in prepubertal period, skeletal effects are really, really limited. And so we are completely agree with this conclusion, but the conclusion means of 3 words: in prepubertal subjects. Okay, this is important. To confirm this data, I want to show you another study published in 2030 in cooperation with the Second University of Naples. We analyzed the skeletal and dental effects produced by Franken 2 in prepubertal patients. Okay? The inclusion criteria were these 4, and the most important thing is an SMB angle lower than 78, a real skeletal class 3 malocclusion. We analyzed 70 prepubertal subjects compared with 70 untreated as a control group. And here you can see the main age of the start of the treatment and the ending of the treatment. Okay? Look the results. No skeletal effect was obtained in the maxilla and in the mandible, but the result was only a dental viral compensation of the teeth. Okay? Again, I want to show you also a clinical case of early treatment of class 2 malocclusion. This is a typical profile of a class 2 malocclusion where the mandible is poorly represented in the face. Intraorally, you can see a class 2 full cusp molar relationship, a class 2 canine, of course, no midline deviation, increment in overjet, a slight crowding in the lower arch, absence of crowding in the upper arch. The cephalometric data shows a clear data of skeletal class 2 malocclusion due to mandibular retrusion and an AP angle of 10. This is a huge class 2. The lateral head film permits the analysis of the vertebrae according with the cervical vertebral maturation method, and the stage is CS1. In other words, prepubertal period. Okay? Our favorite appliance is the twin block, and this is a typical aspect when the twin block is used. Appears an open bite, and there's a complete correction, a sagittal correction, just when the patients use the twin block. And here you can see the clinical result after almost 2 years. Yes, of course, something is improved in the profile. Okay? Now the lips are competent, for example, but probably the position of the mandible is not good, it's not beautiful. And the cephalometric data confirm that when we finished the treatment, the patient was in CS2, again prepubertal period. And cephalometric data shows that the NB angle doesn't change. 9.8, 9.3. No skeletal effect is obtained, but only a movement on the frontal teeth. The upper incisor moved from 114 until 110, and the lower from 101 to 105 on delta compensation. And so, is it worth to treat to obtain an effect limited to the Nordera region? This is a question, but I don't have the answer. Because if you want to treat these patients and you are satisfied to obtain only a dental viral effect, you can use this appliance. Okay? it's very, very important what is the aim of your treatment, okay, and your treatment plan. It's logical now that it's very important identify the different circumpubertal period of growth of skeletal maturity, and for this reason we need of growth indicators. And there are a lot of growth indicators analyzed in the past. Among them, I just remember you the chronological age, the dentition phase, the menarche or void change in obviously females and males. But I want just tell you now that none of these methods are able to detect all the circumpubertal period. And for all, I mean prepubertal, pubertal, and postpubertal. The age range of the pubertal growth peak in males is from 9 to 15 years old, a big period. And for females, from 8 to 14. And inside of this range, you have to detect 2 years, the main duration of a pubertal growth peak. Interestingly, is this evaluation of the dentition phase. When the patients show early mixed dentition or intermediate mixed dentition, probably we are in a prepubertal period. In this study published by the Florence group, Franchi Baccetti and James McNamara, they detect stage 1 and 2 according with the cervical vertebral maturation method in prepubertal period with these two kinds of dentitions. But when the dentition change in late mixed of permanent, the patient could be in each circumpubertal period stage. Okay? These growth indicators are a non-invasive growth indicators. But now we know that no one is able to detect what we want. Okay? For this reason, we have to introduce invasive growth indicators. And the invasive growth indicators are the radiological growth indicators. And I want to remember you the Handel-Rees maturation method, the cervical vertebral maturation method, and the dental maturation. So the maturation of the root of the dent, of the teeth, of the tooth. And today I will talk you just of these two, the first two growth indicators, not of the two. Do you know this method? All of you know the method of cervical maturation method, okay? If you want, we can show it very, very quickly. Yes or no? Yeah? No? Yeah. Okay, perfect. Okay, the most wretched and famous method is the Italian-American method proposed by the Baccetti, Franchi, and McNamara. But I will tell you that the first cervical maturation method has been proposed by Lampartsky a lot of decades ago. Okay, but this is the most famous, published in 2005. The method is a morphological method, okay, and the method is based on the presence of concavity at the lower border of C2, C3, and C4 vertebra, and on the morphology of the bodies of C3 and 4 that change from trapezoidal to rectangular vertical, pass through rectangular horizontal and square. Okay? Combining these two information, the stage is assigned. The concavity at the lower border must be at least 0.8 millimeter deep to be assigned. And according with the authors, CS1 and CS2 are prepubertal stages. During CS1, all the lower border of the vertebra are flat. During CS2, the concavity appears only in the lower border of the second vertebra. Okay? The stage 3 and 4, according with the author, are pubertal stages. During CS3 appears the concavity also in the lower border of the third vertebra. During CS4, the shape of the body of C3 and C4 are trapezoidal. Okay? During CS4, the concavity appears in all the vertebra, but now start to change the shape of the body of the vertebra that move in rectangular horizontal. The body of C3 or C4 or both. Okay? CS5 and 6 are postpubertal stages, periods. During CS5, the shape of the body of C3 or C4 or both is square and rectangular vertical in CS6. Okay, this is the myth. According with the authors, the entire circumpubertal period is divided in 6 moments. Okay, we have 2 years, and this is the 2 years, more years before. We have 3 circumpubertal periods, CS1 and 2 for prepubertal, 3 and 4 for pubertal, 5 and 6 for postpubertal. The author states that sometimes CS2 is jumped in 20% of the cases, and sometimes the duration of CS4 is bigger than 1 year, in particular in class 3 patients. Okay? But as you can see, the duration of the stage from CS2 until CS5 is 1 year each. Okay? Please remember this thing, 1 year each in accordance with the authors. In the last years, some critics raised around the reproducibility of this method in the detect the circumpubertal period. In particular, some authors state a poor reproducibility of the method. Okay? Just for remember you, reproducibility means that all of you in this room are able to see the same thing at the same time or in different times. Okay? This is a good reproducibility. But it doesn't mean that all of we are able to see the real, in this case, stage of the vertebra. Okay? Only that we know the same thing. Okay? In 2014, we published a paper introducing the concept of accuracy. It is a little bit different because it means a great reproducibility, but we are able also to detect an objective staging of the vertebra. Objective, not subjective. Not an interpretation of the vertebra, but the real stage of these vertebrae. To perform an accuracy analysis, we need a gold standard, and the gold standard is the cephalometric analysis of the vertebra. After that, an algorithm assigns the stage of the vertebra. Okay? This is an example of the cephalometric analysis of the vertebrae. To detect the accuracy, we need this kappa coefficient. Kappa coefficient is used in biometrics. It's not an invention of us. Okay, and the minimum value to consider a method with good reproducibility is 0.6. Okay, but I want to show you that the Gabriel and the title of the paper of Gabriel published in 2009 was CVM poor reproducibility. If you look the data inside show